Dr. Nishant?
Yeah. Okay. Hello, everyone. Can you hear me?
Yes, you're audible.
Yeah. Good evening, everyone. I'm Nishant, Secretary Spice Route Movement AFPI Karnataka chapter. I'm working as Junior Consultant, Department of Family Medicine, Bangalore Baptist Hospital. So, Spice Route Karnataka chapter is planning to conduct academic sessions on third Wednesday of every month. There are about 19 DNB and Diploma Family Medicine teaching hospitals all over Karnataka. So Spice Route Karnataka will be a platform for residents to learn, present cases, ask doubts, and interact with fellow residents from other hospitals. So today's session will be moderated by Dr. Sunu Sara Kurian and Dr. Srividya Raghavendran. So can you hear me?
Yeah, we can hear you.
Yeah. So it is my great privilege to introduce Dr. Sunu Sara Kurian, Associate Professor, Department of Gastroenterology, St. John's Hospital. Ma'am has finished her MBBS from Government Medical College, Trivandrum, and MD General Medicine from MKCG Medical College, Odisha. Ma'am has finished her DM Gastroenterology in Government Medical College, Kozhikode. And ma'am is engaged in teaching PG students and has presented in various national and international conferences. Ma'am has also published journals in various national and international journals. Thank you so much ma'am, for coming, and welcome to Spice Route Karnataka.
Okay, thank you.
And it is my great pleasure to introduce Dr. Srividya Raghavendran. She is the head of Department Family Medicine, Bangalore Baptist Hospital. She is the AKT lead for MRCGP International South Asia region, and she is the National NBEMS Webinar Coordinator for Family Medicine. She is the examiner for DNB Diploma Family Medicine exams and also MRCGP. And ma'am is particularly interested in teaching and in academics, and she is interested in motivating and encouraging residents to present in various national and international conferences. Thank you very much, Srividya ma'am, for coming, and welcome to Spice Route Karnataka.
Thank you, Nishant, and it's great to see you all in our Spice Route program, and best wishes for the new team, and I'm sure there is many more to come.
Thank you so much, ma'am.
Today's session will be presented by Dr. Surya Prabha. She is a second-year resident, SNR District Hospital, Kolar. She will be presenting a gastrointestinal case. So during the presentation, it's better to keep the audio muted, and residents can ask the queries in the chat box. We'll clear all the doubts after the presentation. And while entering the session, residents, please enter your full real name and not the device name. Over to you, Dr. Surya Prabha.
Shall I start, sir?
Yeah.
Good evening, ma'am. Presenting the case of Mr. Anand. He is a 40-year-old living in Malu. He is a farmer.
Change your slide. Put to the slide with patient data.
I'm moving forward, ma'am. The slides are moving.
Okay, go ahead, ma'am. Is it okay? Without the slides, I don't know how to go about this. Dr. Sunu ma'am and Dr. Srividya ma'am.
Akshay, do you think you can share the slides if you have the slides with you instead of Surya moving? Either you or Nishant can do.
Yeah, sure, ma'am. Nishant, do you have the slides?
No, right now I don't have.
Okay, I'm just sharing it with you. So you can start sharing, I think. Dr. Suryaprabha, you can stop sharing your screen.
Yes.
Nishant, are you trying?
Yeah, I'm trying. Just a minute. It's coming unsupported document.
Okay, let me.
Let me like post, like I want to share the slide, but it is not showing us. Oh, post.
I'm trying to share my screen 1 second. Are you able to see?
Yes, ma'am. Yes.
Yeah.
Okay, ma'am. So if I scroll my screen, are you guys able to see the details? Now? Are you able to see?
Yes, ma'am.
Ma'am, are you
Yeah,
able
we
to
are
see,
able
ma'am?
to see.
Okay. Surya Prabha, you can read from yours. I'll change here.
Oh, okay, ma'am.
Yeah.
By occupation, he is a farmer. Date of admission is on November 5th, and I examined the patient on November 11th. Then she complains abdominal distress since 6 months, swelling of his lower limbs since 4 months, yellowish discoloration of eye since 8 days, and fever since 4 days. Then about history of presenting illness, abdominal distension since 6 months. Patient was apparently all right 6 months back. Then he noticed abdominal distension, which was insidious in onset, gradually progressed to massive distension, and distension which changes with position, and it is diffuse in nature. That is not associated with abdominal pain, constipation, vomiting, not associated with dyspnea. After admission, patient underwent paracentesis. This is the current status of that abdominal distension.
Go ahead.
Then swelling of lower limb, that is since 4 months, which is insidious in onset. Initially involves only at the feet, but gradually progress up to knees. Present throughout the day, and it is reduced on lying down. It is not associated with scrotal swelling. There is no history of chest pain or palpitation, no history of facial puffness or decreased urine output. Then about the yellowish discoloration of eye, it was since 8 days. It is acute in onset, gradually progress. It is noticed by this white, which is not associated with itching, high colored urine, or pale stools. Then fever since 4 days, which is high grade, which is associated with chills and sweating, is continuous in nature. It is relieved by over-the-counter antipyretics. It is not associated with joint pains or rashes. Patient also complains of increased sleepiness during day and sleeplessness at night for 4 days. No history of difficulty in breathing, orthopnea or paroxysmal nocturnal dyspnea. No history of confusion or altered mental sensorium. No history of hematemesis, bleeding, blood in stool or melena. Ma'am, shall I move forward past history?
Go ahead. Don't stop, ma'am.
Okay.
Ask him.
Okay. Past history. History of hepatitis was there 1.5 years back, for which he was admitted in a local hospital, and treatment was taken from there. There is no history of tuberculosis, asthma, diabetes mellitus, hypertension, heart disease, or seizures. No history of blood transfusion or tattooing or chronic drug intake. No history of recent travel. No history of surgery. Then family history. No history of similar complaints in the family. Then about personal history, he's a farmer by occupation. His diet is a mixed diet and decreased appetite since 1 week. And his sleep is disturbed at night and increased during the time. And bowel and bladder habits with normal limit. He's a chronic smoker, that is 10 years. Used to smoke 10 cigarettes per day for pack years. He's an alcoholic. He used to consume 180 ml of brandy daily since 20 years. And there is no history of IV drug abuse. Social status, married and in a monogamous relationship with his wife. Then about the summary, 40-year-old male with significant history of 20 years of alcohol consumption, past history of hepatitis, treated by native medicine, presented with abdominal distress since 6 months, swelling of lower limbs since 4 months, yellowish discoloration of eyes since 8 days, fever since 4 days, also with altered sleep patterns. His condition probably involves a gastrointestinal system. Provisional diagnosis is acute decompensated chronic liver disease with symptoms suggestive of portal hypertension and hepatic encephalopathy, with probable etiology being chronic alcohol consumption. Other differential diagnoses are viral hepatitis, toxin-induced liver disease. Then about general physical examination. Patient is awake, irritable, oriented to time, place, and person, emaciated and malnourished. His height is 158 centimeter. Weight is 60 kg. BMI is 21.3 kg per meter square. Pallor present, icterus present, edema present, bilateral lower limbs. There is no cyanosis, there is no clubbing, no lymphadenopathy. Then head to toe examination. Hair is normal. Palmar erythema is present. Then two spider navy, one on chest and one on back. Then pale colored nails. Then gynecomastia are present. Then flapping tremor is present. Parotid swelling, debutrans contracture, testicular atrophy, petechiae purpura not present. Then vitals, temperatures 100.60 Fahrenheit measured always. Pulses 60 beats per minute, regular rhythm, normal character, volume, and no radial delay or no radio delay. No, all peripheral pulses are palpable, equally well bilateral. Then blood pressure 100 by 60 mmHg measured in right upper limb in sitting position. Respiratory rate is 60 per minute. Thoraco-abdominal nature, JVP is not elevated. Then systemic examination, lips normal, teeth multiple caries present, tongue is normal, no angular stomatitis, no cheilitis. There are no ulcers or patches on palate or mucosa. Then for abdominal examination, patient is exposed from nipple to mid-thigh region and examination done in supine position. Inspection. Abdomen is uniformly distended and flanks are full. Umbilicus is displaced to downwards and horizontal slit present. The corresponding abdominal quadrants moves equally with respiration, that is upper and lower quadrants. The skin is shiny, no striate, no scars, no discoloration, no scratches, no sinus. Any veins present over abdomen, no visible pulsation of peristalsis. Hernial orifice appears normal. External genitalia appears normal. Then palpation. Abdomen not warm or tender. No abdominal rigidity or guarding. Abdominal girth is 106 centimeter. Direction of flow of blood in encourse veins are away from umbilicus, above and below. On deep palpation, no palpable mass was appreciated. Then percussion of the liver. Upper border of the liver dullness is percussed at right fifth intercostal space along the midclavicular line. Lower border isn't appreciated. Percussion of the spleen, the dullness noted in the ninth intercostal space of anterior axillary line. Drop space is dull on percussion. Shifting dullness was present. Fluid drill was not appreciated. In auscultation, vowel sounds were present, no bruit or no venous hum. Then other systemic examination, CNS examination, patient was awake, irritable and oriented, no focal neurological deficit, flapping tremor present, no other involuntary movements observed. Then respiratory system, normal vesicular breath sounds, heard bilateral, no added sound. Cardiovascular system, apical impulse heard of fourth intercostal space. In midclavicular left side, then S1, S2 heard, no murmur was present. Provisional diagnosis. My diagnosis for this patient is chronic liver disease with features of portal hypertension, hepatic encephalopathy due to chronic alcohol.
Ma'am, you want to ask questions now?
Okay. So in your history, you said patient has been having abdominal distension for 6 months, and there's no description in between, you know. What was he doing these 6 months? Is it now that he's come to hospital, or?
Used to come, but he's not admitted. When a patient, if the patient is having abdominal pain or something, patient used to come to OP and he will go like that only. He didn't had any inpatient admission actually.
So he wasn't evaluated, was it?
No, ma'am.
Okay. Okay, and also the rest of the history seems okay, except you also mentioned in past history that he has history of hepatitis. So what was it that the patient actually said?
Patient is a chronic alcoholic. He had a history of
No, in the patient's words, you know, did he say hepatitis? Because hepatitis is different from jaundice. Yeah.
He said to me that for jaundice he was admitted and he had a discharge summary of the previous admission.
Okay, so whenever the patient has a past history of hepatitis, you don't, you could take a little bit of history, whether that would give you a clue. So later, when you want to work up the etiology, you know, that would give you a clue, like what was the cause of that hepatitis or jaundice, as you would say. Was he admitted or?
He was admitted, ma'am.
Was that prodrome prior to the jaundice, or was there a binge drink of alcohol prior to that?
He said he had a history of binge drinking of alcohol. After that, he got admitted. 20 days he had admission.
Okay, so then you can modify your history to say that 1.5 years back he had a history of jaundice, okay, which was preceded by say binge drinking. So that would give you a clue as to what it was. It could have been an episode of alcohol-related hepatitis, as against a viral hepatitis. So, right?
Yes, ma'am.
Yeah. Okay. Now, another thing is you also mentioned somewhere that patient underwent paracentesis.
Yes.
So you could get some more details, like, you know, how much fluid was removed, what was the color, you know?
Yes.
Yeah.
After admission,
All in the what's, yeah.
After admission, third day diagnostic paracentesis done, ma'am. Straw colored.
Yeah. So you can include all those details in the history to get a more complete picture. Okay. Yeah. And so any other DDs that you have in mind at the end of your history, how would you summarize the case at the end of the history, you know, before going to examination? Yeah, okay. You already summarized. Would you have any other DDs in mind?
Viral hepatitis B and the other than.
No, that is a clue, you know, your DD for the etiology.
No familial history is not there.
Sorry?
No familial history and workup for hemochromatosis and Wilson's disease, that metabolic.
No, my question is regarding the syndromic diagnosis. Okay, you say this condition probably involves the GI system. I think you can be more or less more specific. This is involving the liver or the hepatobiliary system. Okay, so within that, besides cirrhosis liver, okay, would you have any other DDs? That is what I'm. Cirrhosis due to any etiology. Besides that, would you think of any other DDs?
Any cardiac failure.
Congestive cardiac failure, you're thinking?
Cardiac failure.
Okay, lower down. But okay, before that, anything else?
Because of ascites, is that constrictive pericarditis.
Okay. But he doesn't have any breathlessness or anything like that.
No history of breathlessness.
Anybody else want to volunteer with any other DDs?
Nephrotic syndrome.
Why would he have jaundice and fever? Does anybody else want to volunteer?
Peritonitis.
No.
Bacterial peritonitis.
Yeah, spontaneous bacterial peritonitis occurs in the setting of a cirrhosis. Okay, so this could also be, say, chronic Budd-Chiari or disseminated METS or a disseminated tuberculosis. So all this has to come in our DDs. Okay, so that's what the rest of our examination and our investigations, we should keep it in mind. That's what I'm trying to say. Right? Okay. Okay. And you also asked for family history. What is the relevance of family history in liver disease?
Metabolic syndrome, that metabolic disease, hemochromatosis.
Hemochromatosis is nearly not reported at all from India. But what are the other more common causes that can run in the family? Of
Viral
hepatitis.
hepatitis.
Viral hepatitis, yes. Viral hepatitis. What else? Viral hepatitis. That is very rare, nearly non-existent, at least in India. Especially what are in southern India, especially Tamil Nadu and Andhra Pradesh, also Karnataka, Wilson's disease. Okay. Wilson's disease. So here we have an etiology glaring at us. Alcohol. He has history of significant alcohol use, but we should think of other etiologies as well. That's the message I'm trying to get across. Okay. Okay. And another thing is you could also take a short history as to see, whether he has a significant alcohol use disorder. Have you heard of certain criteria called the audit score or audit C score?
Other participants can also answer this question. Doesn't need to be Surya alone.
Yeah, so somebody has messaged case criteria. Yes, case criteria is one. You can also use something called the audit C score. Okay, just to see whether the patient has, alcohol use disorder, because that would mean that he would also be, under the care of a psychiatrist. So these are some small things that you will have to take in the history. Okay. Okay.
What about the socioeconomic scale, the Kupasamy scale? Have you done that, Surya? Where is the patient placed in?
Patient is a farmer and he studied up to 8th grade, lower middle class.
Why is this important?
He don't know about the condition of this disease and complications.
So one is regarding the nature of the illness and the complications, and number two is as we all know, with rising healthcare costs, the financial commitments, and how much do we treat, what are the implications involved, where we can get help, and will the patient follow up and be compliant with the treatment given by us. All these are crucial in managing these patients. So it's important to understand the socioeconomic status and never forget to put that in the history taking. Yeah.
Okay. So then how would you work up or how would you investigate?
Viral markers.
First.
First blood routine.
Yeah.
CBC, total blood.
Okay, what do you look for in the blood routine?
Fever is this, will be elevated. Total count will be elevated and hemoglobin will be less. Anemia will be.
Yeah, so anemia may be there. Need not always be there. Anemia may be there. The total counts may be high. Can you tell me 2 causes in this particular patients why the total count may be high?
Viral hepatitis.
No, somebody has messaged SBP. Yeah. So any underlying, remember this patient has fever. So this, it could be any source of infection like say an SBP or a urinary tract infection. What about any other non-infectious causes in this particular patient? Another thing I forgot to say is you haven't mentioned when his last drink is. Okay. So you have to take that history as well. Okay, you're right. Somebody has written alcoholic hepatitis. So in alcoholic hepatitis, you may have leukocytosis even without there being frank infection. So by definition, can anyone tell me what alcoholic hepatitis is? Okay, just read it up. Okay, so in CBC, you look for hemoglobin counts. What else?
Then
Platelets.
count will be low.
Yeah, thrombocytopenia. Okay.
Thrombocytopenia.
Okay, so that's CBC. Then
Then
after CBC,
then LFT.
yeah. What do you look for in liver function test?
Bilirubin will be elevated more than 1 point.
In which you are okay? Tell me about this patient and tell me about this patient. Do you know? Do you have the LFT of this patient?
Yeah, ma'am. LFT is more actually more 11 10 to 10 point something, ma'am. 10.63.
No. We have to know the whole LFT. We have to know the bilirubin, the enzymes, because everything we have to know. Only then. Yeah. Okay, so you don't have it. Okay, so can somebody unmute and tell me what the LFT can tell us? No? Okay, do you know when this patient last had alcohol?
1 week back, ma'am.
1 week
Before
back.
admission, 1 week back.
Prior to admission. Okay. Okay. So somebody's mentioned ASTL. So depending on the pattern of the LFT, it could give you a clue. If he is having alcoholic hepatitis, his bilirubin would be more than 4 to 5, and his AST and ALT would be elevated with AST being more than ALT. Okay. Huh? With GGT and ALP high as well. Okay, and typically the AST ALT is between say up to 500. It can go as high as 500. Okay, so just looking at the LFT, it could give you a clue as to the fact that the patient has alcoholic hepatitis. So remember, the other side to be remembered is not all cirrhosis or not all chronic liver disease patients need to have an abnormal LFT. A patient can have cirrhosis even with a normal LFT, but that's another discussion. We'll stick to this patient per se. Okay, so you've looked at the LFT. What else? So I'm assuming this patient has some sort of alcoholic hepatitis.
Yes.
Okay. Okay. What about what next?
Coagulation profile.
Okay.
INR of the patient was elevated.
How much?
3.
3. Okay. INR is high. Okay. What else? So you've done CBC, you've done LFT, INR. What else?
Then ultrasound.
Before that?
RFT.
Okay.
Serum electrolytes.
Yeah, tell me why. Yeah, it would have been good if you had this patient's reports. Otherwise, yes, creatinine renal function test. So it could tell us whether the patient has acute kidney injury or chronic kidney disease if you have a baseline creat to compare with. Okay, what else? What next in the blood investigations?
Parasynthesis.
Okay, and anything else in the blood investigations you want to know? You had said earlier, I think, viral markers.
Yes.
Right?
Correct.
Yeah,
HBsAg.
HBsAg and anti-HCV ELISA. Okay, so this patient is negative?
Yes, ma'am.
Okay, so this patient is negative. Okay, then what next?
Then ultrasound.
Okay. So, what do you expect? What is the ultrasound finding of this patient? Do you know? If you don't know, you can tell me what you expect in a patient with cirrhosis.
Rose ascites was there, splenomegaly was there.
Hmm.
No hepatomegaly was there.
No. So, how is the liver described in his ultrasound?
That last question only I sorry, ma'am.
Okay. Okay. So tell me what you find in, okay, or I'll tell you. So in chronic liver disease, yes, coarse echo texture is not very specific. What you're looking for is a nodular liver, coarse echoes with nodular liver. So it's very it's quite common nowadays to see ultrasounds with reports of coarse echoes, but that's not what we're looking for. Nodular liver is more specific. Then, of course, other signs of portal hypertension like you said, splenomegaly, ascites, and presence of collaterals, a dilated portal vein. Okay, so these are the other signs. What else do you look for in ultrasound? Remember, these patients are prone to develop tumors or HCC. Huh? So you also look for any space occupying lesions in the liver. So a good ultrasound report will contain all this, whether the liver is nodular or not, whether there's a splenomegaly, whether there's ascites, collaterals, the size of the portal vein, okay, and the absence of space occupying lesions. Okay, what else? Also, if you have the suspicion of a Budd-Chiari in mind, what will you look for in the ultrasound? You will look for the hepatic veins and, right, somebody has mentioned hepatic veins and the IVC. Okay, they have to be patent. If any of those are blocked or occluded, it suggests Budd-Chiari as a possible etiology. So remember, you can have alcoholics also with Budd-Chiari. So just because he has alcohol in the history, doesn't mean you don't think about the other causes. You still have to rule out all of this. Okay, so now you have an ultrasound. It's suggestive of cirrhosis. Here's ascites. Then any other investigation you want to do? Okay, urine routine to, okay, rule out infection. What else? Ascites. Yeah. Why do you want to do a diagnostic tap in this patient? What is the aim of doing a diagnostic tap? It would be good if someone could unmute and say.
Is a SAG values will be elevated more than 1 point.
Okay.
Transudate or exudate?
No. SAG is to rule out this ascites is due to portal hypertension. The SAG will tell you, a SAG of more than 1.1 will tell you that if it's more than 1.1, it's portal hypertension. Okay. What else from diagnostic? Anyone? In this patient, he's got fever, no? Yeah, you have to rule out SBP. How do you rule out SBP? Yes, neutrophil counter 250 or more. Okay. Okay. Do we have this patient's fluid analysis, or is it done, or is it done?
Yes, it's done, ma'am. But patient.
Sorry.
Patient referral actually referred to higher center.
Okay. Okay. So at this, so supposing this patient has a high SAG. So, like, how do I take the discussion from here? I mean, do we assume that the patient is referred to a hepatologist, or, you know?
As we don't know the management plan, what has happened in this particular case, maybe
Okay.
we can discuss about how to manage these patients when they see them in the, let's say, in a district
So
hospital, what needs to be done, what are the things they could do at their level, because at
Right.
tertiary center they may not, family medicine residents may not be involved in it, but in a district hospitals or in a community health center, what are the roles, what are the things they can do and what they should be learning to do. So the focus, if we can focus on that, maybe that might be useful. Yeah.
Okay. So So this patient, I'm going to assume he had no SBP, okay, and his ultrasound is otherwise suggestive only of cirrhosis and nothing else, no blood carrier or anything else. Because in those cases, I think it would be best to refer. So first is you have a high sag, low protein ascites. Okay, the protein is also low. That you have to remember. If it's high sag and high protein, you have to think of causes other than cirrhosis. So remember, in cirrhosis, it's a high sag, low protein ascites. Then you start the patient on diuretic, assuming that his creatinine is normal. Now, what diuretic do you start the patient on? You can start the patient on. Sorry?
Spironolactone, furosemide.
Yeah, furosemide, spironolactone combination. Okay. And then how do you, then the other thing is he would require an endoscopy. An endoscopy is not an emergency because in this case, the patient does not have history of a GI bleed. Okay. But at some point, he would have to be referred for an endoscopy. Right?
Okay.
Okay. So here the thing would be to reduce his edema. What can be done, at say a district hospital level would be to reduce his edema first, okay, and treat any infection if present. Okay.
Akshay, is the meeting still on or?
Yeah, ma'am. I think ma'am got
Ma'am's got
disconnected.
disconnected.
Okay, all right. So till she comes back, Dr. Surya, how did you manage before sending to the patient to the tertiary care center? What are the things? Let's say you are in your emergency room duty and you see this patient. What would be the initial management you will do for this patient? You have sent all the bloods, you have done these things. What will be your first line of treatment?
Start with antibiotics will start. Then
Will you start antibiotics first? Let's say his abdomen distension is quite extensive. What will you do first?
this furosemide 40 mg and spironolactone will start.
Yeah, paracentesis is definitely therapeutic tapping. Yeah. Should we do along with furosemide or should we do it separately?
First, depending upon the grade,
Others can also answer.
Yeah.
in moderate ascites, restriction of sodium and diuretics will start.
Yeah.
Then
Correct.
in large ascites, paracentesis.
So if the
And
patient is in distress, definitely therapeutic paracentesis will be useful, along with simultaneously adding the diuretic, keeping an eye on the electrolyte. What else can be done?
How much fluid would you remove?
Yes.
Okay, the thing to remember is if it's a massive ascites and you're removing, say, more than 5 liters, then you would have to supplement albumin. Okay. Okay. So if it's a resource limited setting, and the patient has other financial issues, you could always remove less than that, and then also simultaneously start diuretics as long as his creat and his electrolytes are normal. Okay. Okay. Anything else? What else? So another thing is he has to be on laxatives. Okay, most important thing, it's quite important that they pass stools 2 to 3 times a day, soft stools. So you add laxatives and you titrate the dose. You can start with say around lactulose around 15 ml at night and titrate the dose so that he passes stools around soft stool around 2 to 3 times per day. Right. Somebody has written antibiotic if SBP is there. Which antibiotic would you start? Norflox or ceftriaxone, okay, or Piptas. So that actually depends on the hospital antibiogram. But right, okay, you would give antibiotics for how long?
Cefotaxib TID for 5 days.
5 days. So with SBP, the patient has SBP. Another thing you have to remember is they are prone for what is called hepatorenal syndrome. Okay, so you also have to even if the patient's creat is normal or the renal function is normal, you would still have to supplement albumin on day 1 and day 3 in order to prevent HRS in these patients. Okay, so SBP is one of the indications of albumin in cirrhosis patients. One we discussed earlier is when you remove large amounts of fluid, you have to supplement albumin. Another is SBP, when on day 1 and day 3, you would have to give albumin. Okay, then somebody mentioned rifaximin. Is there a role for rifaximin in liver disease? This patient, yes, because he is in hepatic encephalopathy. Okay. Okay, so any patient with hepatic encephalopathy or with previous history of hepatic encephalopathy, you would have to give rifaximin. Okay. Anything else? What about beta blockers?
Portal hypertension. Propanol.
Yeah. Do you want to give in this patient? What is the indication for beta blockers? Okay, that depends on the varicose status, which we don't know. So as of now, we wouldn't give. Okay.
And if SBP is there, what follow-up medicines have to be after cefotaxib follow?
Yeah, so up until now, the guidelines would say Norflox for up to 1 year, but now the guidelines are slowly changing. So yeah, so as of now, till now they say Norflox until 1 year or until transplant. So on antibiotic prophylaxis. But if, for example, in this patient already has hepatic encephalopathy, he would already be on rifaximin. So even that alone would suffice in this patient's case. I hope I'm clear. For example, that is, this patient would already be on rifaximin because he has hepatic encephalopathy. And so for him, this rifaximin alone would suffice to cover for the antibiotic prophylaxis for SBP as well. Okay. What else? Anything else? So how would you monitor this patient? You started the patient on diuretics. You've started anti-coma measures.
Albumin will measure. Albumin.
Albumin?
Hypoalbumin. There's a monitoring of albumin and electrolytes. BP.
No. Yeah, okay. There's no need to measure the albumin as such because our treatment, it doesn't change the treatment in any way. Okay, so I'm sorry. Another thing is this patient is in minimal HE. Okay, so would you start diuretics for this patient?
Ascites is there. So
I think ma'am got disconnected again. Vidya ma'am, you want to ask anything or tell us anything, ma'am?
No, the few things which I had in mind was one regarding the treatment of ascites when they come. And I also want to focus on future prevention. What are the, let's say this patient gets the ascitic tab done, treatment is done, you're discharging the patient. What would be the advice given on discharge and further follow up? What as a family physician we can do so that this doesn't come back again? What are the things which can be done?
Salt restriction, fluid
How much
restriction.
is the fluid restriction? How much is the salt restriction? Abstinence from alcohol, that is definitely an important thing. And looking at the history, this patient needs a long follow up, working along with the psychiatry team, de addiction team. Definitely, yes. That's where we should focus on and help him in this process. What next? Salt restriction meant how much salt restriction and why there should be a salt restriction.
Less than 2 grams.
What is the logic behind it? Why you came up with a number? Less than 2, somebody has said 5.
2 gram per day.
Hello?
Restriction. So sodium less than, sodium should be intake should be 2 gram per day.
Okay, check on that number exactly to restrict to prevent water retention, correct?
So a
Also-
more practical way of telling them would be to put no extra salt in their diet because it's not possible to measure. So, okay. So like ma'am said, the most important thing would be the patient needs to be strictly off alcohol. It's easier said than done. So we have to work closely with the psychiatrist because a lot of the medicines like anti-craving and all cannot be used when the bilirubin is very high. So always work, we would need their help as well. So that's the first thing. The other thing is, you have to titrate the dose of their diuretics, depending on salt restriction, as we already said, and water restriction to say only if there is overt edema. Otherwise, you don't advise water restriction as such. If there is too much edema, then you say around 1.5 liters per day. Okay. And then what else? So remember, cirrhosis is progressive. So they would need to be under constant follow-up. So at some point, you would have to refer them to a gastroenterologist for his endoscopy. So assume that they've been seen someone at a tertiary care center, and then they're coming back to you for follow-up. Okay, then how would you follow them up? They are with you. These patients need to undergo regular or every 6 months, they need to undergo ultrasound abdomen because cirrhosis is a precancerous condition. HCCs may form at any time. So that's why, right, AFP and ultrasound abdomen is to be done every 6 months. Okay. Anything? Okay. Somebody's asked me role of UDCA. There is no role of UDCA. No role.
Fibroscan.
So once a patient already has frank cirrhosis, he's already decompensated, then the fibroscan doesn't really have much role. Plus, in the presence of too much ascites, it would not give you a right value anyway. Okay. Any other queries or?
ವಿಷಯಕ್ಕೆ ತಿಂದ್ರೆ ಗ್ಯಾಸ್ ಆಗುತ್ತೆ ಬೇಡ.
When okay. When to do fibroscan? Like so not for this patient per se, is the because he already has cirrhosis. Okay, he's already decompensated. He already has ascites. So we wouldn't do it for this patient. We do fibroscan for those patients in which there is a doubt. Like some very stable patients come to you with say some signs of a cirrhosis liver, but you're not sure, then you may do it. AFP, yes. AFP every 6 months as a screening test to rule out an HCC. Diuretics in hepatic encephalopathy, diuretics are to be avoided. Right, vaccination as well. You would advise them for vaccination against hepatitis B, A and D, A and A, yeah. Right. Yes. MELD and child Q score. So yes, that's also important. Okay, so you calculate the MELD score. One is that will tell you the severity of liver disease. Another thing is, when do you refer them for a transplant? Okay, so you refer a patient for transplant at the first decompensation or when the MELD score is more than 14. Okay, it doesn't mean that every time a patient decompensates in the first visit, you tell them they need a transplant. For example, for this patient may have had an element of alcoholic hepatitis, which is one reason why his MELD score could be high. So once he's off alcohol for, let's say, around 6 months, sometimes they improve on their own. So you have to give them some time. Yes, pneumococcal vaccine as well. All these vaccines have to be given. Nothing else. Is there any more queries or?
Thank you so much, ma'am. Ma'am Srividya, ma'am, anything from other aspects from family medicine point of view that you want to add or ask, ma'am?
So the few things which I majority have already been discussed. Dr. Sunu was really good. Thank you so much for your taking time and being part of our session. There's a lot to learn for our residents from you, and really thank that you could spare some time. Surya, when your few things with regards to the case presentation. So when we are presenting this case, I think when we are seeing a patient, the way we go through the history is to understand how the symptoms are progressing, right? So it's important that you go through the history sequentially. Yes, you told 6 months, 4 months, 3 months, but you should present it like a how the symptoms evolved over a period of time. So this gives you an idea of the progression of the symptom as well as for the examiner. That is something you should practice on. You did try. We would like you to practice a bit more on the history taking a bit more rather than telling yes and no, no family history, no negative history, those kind of things. Number two is, as I was mentioning earlier, how would you manage in a different setting? That is something which is very important. And three, focusing on follow-ups, future prevention. I'm happy to see the vaccination discussions and things. So those are the areas to do. With many more case presentations, I'm sure things will get much better. Thank you so much. Thanks, Akshaya and Nishant.
Thank you so much, ma'am. Thank you, Dr. Sunu. It was, I think, very insightful for all the students. And Nishant, you want to take over?
Yeah. Thank you, Sunu ma'am and Srividya ma'am, for moderating this session. I'm pretty sure the residents found it very useful. And thank you, Dr. Surya Prabha, for coming forward to present the case. You presented really well. And we'll be having the academic sessions every third Wednesday of every month. And our next academic session will be presented from Ballari Hospital next month. So residents who want to present cases, please come forward and contact Spice Route Karnataka or PG coordinator Dr. Sirisha. She will help you, and we'll be we'll be able to plan for a session and arrange the moderators.
Yes. Thanks a lot. Thanks a lot, everyone. And
thank you all the residents for attending this class, and I'm sure it will be of great use to you.
Thank you. Thank you.
Nishant, 1 second. He asked me to end the recording. I don't know how to end that. I just press the record button, is it? Do you know how to end the recording in a meeting? You're able to hear me?
Yeah, yeah.
Should I just press? There is one record button in the bottom.
Stop
Should I just press-
recording. No?
Yeah, do you know how to do that?